Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act.
Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Green.
We promise this will be the last in this series, and it should be a short and sweet one. We didn't realize we had so much to say in our last one, but I hope that you guys have found this series of hormones, specifically for perimenopause and menopause women, very insightful and educational for maybe yourself or even the lovely women in your life. So, before we get into this episode, we are going to share our weekly Bible verse, and mine is coming from Ephesians 2:10 that says, "For we are God's handiwork, created in Christ Jesus to do why is it doing that? Good works which God prepared in advance for us to do."
And then mine is coming from James 1:5. If any of you lacks wisdom, if any of you, that's an error. If any of you lacks wisdom, you should ask God, who gives generously to all without finding fault, and it will be given to you. Girl,
we are obviously firing on all cylinders today.
Oh boy, yeah.
My dog was being a pain, as she likes to do when we record, it seems like. I think she has a sixth sense or something.
I know. She is a girl.
Yeah. All right, Andrea. So today's episode is all about answering some questions that people might have regarding, specifically HRT, hormone replacement therapy, maybe what other things maybe to expect during this time transition for women. Let's start off with a big question that you probably get a lot, but also I've gotten is, are there any supplements that are not HRT that I can be taking or doing to help with this time period?
Well, yeah, that is a really good question. And I do get that question all the time because working for a, functional medicine practice, people are always curious about how can I avoid prescription medication? How can I avoid going on drugs, as it were?
Yeah.
And so, yeah, I totally get that. However, there's always the however, right? When it comes to, and we'll talk about, so we've done shows on progesterone, estrogen, and testosterone, and these are the major movers when it comes to all of the symptoms that we're talking about. And, we've talked about how protective these hormones are, and why we need them. And so in terms of how to keep levels high, here's what I'll say. This is a very nuanced question because it kind of depends. If a woman is just like barely perimenopausal and things are just starting to get a little wonky, then yeah, there are some things that you can do. So first of all, what you can do is control your stress, because the body, and I was just explaining this to a patient yesterday, that the body is a master of triage, right? Its prime directive is to keep you alive. And so if it thinks that you are running from a bear, then it will prioritize making stress response activities will be prioritized over making sex hormones. I mean, what do you care if you're releasing an egg or where you are in your cycle if you're running from a bear? It just doesn't matter. So it triages, and if you don't control that stress, it will take those raw materials that it would normally make sex hormones out of, and it will shunt those down the stress response pathway. Does that make sense?
Yeah, because remember, guys, our body's only job, priority is to survive. That is literally the only thing that it is out to do. And so just like Andrea said, if it is in a fight or flight mode, it's going to stay in that, and that's because that's how it feels. It needs to survive.
Right. Right.
I was going to say something else, but I forgot. Um, so ways that we've talked about ways that we can control our stress, obviously, and we emphasize this one a lot is sleep. If you're
Mhm.
not sleeping well, your stress is most likely going to be through the roof because your body is so tired.
Exactly.
Prioritizing sleep is a great way to start. And
Mhm.
if you're not sure on how to do that, go back to our sleep episode where we talk about ways that you can help improve your sleep.
Right, exactly. Now I will also say that, weight loss, even small amounts of weight loss can help to balance hormones. Again,
Mhm.
not these wild swings that we need to take care of a little later in the process, but if you're just starting down this journey, then yes, stress reduction, a little bit of weight loss, that because here's what happens with excess adipose tissue. So as we put on weight, fat actually is estrogenic. It creates its own supply of estrogen. And so, in the if you have low estrogen, then this is not going to be helpful for you. However, if you have elevated estrogen or estrogen dominance, then you can lose some weight, and that is what creates that is what will back off that estrogen production so that you can have a little better balance.
And I
Yeah,
know what women are going to be thinking that are listening to this. I'm trying to
I
lose
know.
weight.
Gosh, I know. I know. Girls, I'm right there with you. I'm right there with you in the trenches.
So both Andrea and I's biggest thing is what are your lowest hanging fruits that you can control?
Mhm.
So one thing that you can start controlling is sleep. That's going to be a
Mhm.
huge one.
Right.
Sleep is such an underrated fat loss,
Yep.
quote unquote magic.
Mhm.
That you guys, if you're not sleeping, then definitely make that a priority.
Mhm.
Another low hanging one is get your freaking protein in.
Yep.
Um, especially
How do you
as
feel about that, Ashley?
I know. I'm so tired of the excuse. I don't know how to eat more protein. I'm like, just do it. Like, go get a freaking chicken breast if that's what you need to do and
Yeah.
eat it.
Mm.
Like
Yeah.
3 ounces is what, 24 grams of protein right then and
Yeah.
there. Um,
Yeah.
get a protein supplement shake. That's so
Mhm.
there's a supplement if you want one.
Right.
Get a
Right.
supplement shake for protein.
Yep.
Um, you
Yeah,
know,
so let me tell you, I just in fact, right before this show, that's why I was late. I was slamming 48 grams of whey protein because that's, sometimes that's what I got to do.
yep.
And you can't always get, 120 or 50 grams of protein a day from pristine grass fed or go out and shoot your elk sources. It just needs to come from somewhere.
Yeah. And I think a lot of times we, especially as we age, uh, or not even age, but maybe just become more educated in our food quality,
Mhm.
we're focusing more on the perfection side rather
Right.
than just getting in the protein that we need. So,
Yeah. Yeah.
consistency over perfection. Okay, so another one that I know people are probably wondering because you mentioned several times in the previous episodes of like having a reputable source for a hormone replacement therapy, and like there's multiple clinics out there that you're like, yeah, you can go to Joe Schmo on the street and get some
Mhm.
hormone replacement therapy,
Mhm.
but it's not necessarily a quality source, right? So
Right. Yeah.
where can people find a quality and reputable provider to be able to administer HRT?
Yeah, actually, I'm sorry. Can I go can I go back to the previous question, I just want to say two more things on this.
Oh,
So,
yeah.
in terms of providing, I just thought about this. So, in terms of providing the raw materials, so we've talked about stress response, we've talked about weight loss. Now, I want to tell you how to give your body the healthy raw materials that it needs to actually make hormones. So, you need healthy fats, you need omega 3s. All of those things that you know are healthy fats. There's been this campaign against vegetable oils, and rightfully so. Um, but we need healthy fats. So that's going to be avocado, olive oil, grass-fed meats, grass-fed butter. That's going to be red palm oil. All of those things that we know, coconut oil. Okay. So I'm not going to belabor the fat point. The next one is you also need zinc and vitamin C. That will
Oh,
help
yeah.
to create hormones as well. So
Mm.
zinc and vitamin C, you can take 750 milligrams of vitamin C, or I would just say between 500 milligrams and a gram a day will do it. And then on zinc, I always like people to pulse it. I've said this before, but 30 to 50 milligrams a day. Pulse it, take it 5 days a week, have the weekends off, or take a week off a month.
Okay.
And now we
Perfect.
can move on. So, yes,
All
reputable
right, so
provider.
yeah. So if you
Um,
if you're like, "Hey, I think I am wanting to go
mm,
down the HRT route," where should I start looking for a place to go or to get it?
yeah. So, I will, gosh, and I've said this before on a previous episode about these hormone clinics that drive me crazy. It's basically your hormones are part of a complete system, right? So I find it really difficult. Like one of the things that we rail against and that we don't feel that conventional medicine is doing a great job of is this reductionist medicine where everybody's got their little piece of it. So here you have this poor patient and we're sending them to, oh, your kidney function is off. Okay, I'm going to send you to nephrology. Oh, your blood sugars are wacky. I'm going to send you to endocrinology. Oh, you've got, a frequent recurring unremitting headaches. I'm going to send you to neurology. You have palpitations. I'm going to send you to cardiology. Well, we're all talking about the same person. And so, we need to get together and realize that the holistic nature of a human being, it's all connected. And so when we put all these different body systems in silos, then nobody talks to each other, right? And you
Mm.
don't get a whole look at the person. And so the same is true for hormone clinics, right? They are just looking at numbers on a page. And I'm sorry, but if you're not looking at the whole person, then that's not good care in my mind. And there are probably some hormone clinics that are out there doing it right, looking at the whole person, and working with primary care, etc. But I got to tell you, there's a lot where I live. And I spend a fair bit of time fixing their messes because patients come in really messed up. I think I told you guys that, I've had women come in with hormone levels, testosterone levels that are like a teenage boy, like a 20-year-old man. And their hair's falling out and they are aggressive and they've got acne all over their chest and back. And it's like, are you kidding me? And they still write these prescriptions. So yeah, it's a problem. I would say, your best bet, and I'm obviously biased towards primary care because I love what we do. I think it's the hardest job in the world, to take care of people from head to toe. But if you've got a primary care who is knowledgeable about hormones, that's really what you want because they know your story. They're not looking at just one little chapter of your life. They're looking at the whole thing, or at least they should be.
So somebody hears that and says, "Okay, so where do I start looking?"
Yeah, so it is perfectly understandable, logical, a good idea to go in and have a visit with a provider. Like read their history, right? We all have bios, we all
Mhm.
have information about ourselves that you can find online. Um, do some digging. See what kind of training this person has had. See what kind of clinic they work in.
And I know some of them will have actual client reviews on there, like
Mhm.
depending on the website
Yeah.
or the platform
Yeah.
that they're listed on.
Exactly. And some of those things, it's kind of a double-edged sword because, you won't click with everybody, and I'm sure there is a terrible review out there about me or two. I don't know. I don't go looking for it. But, take these things with kind of a grain of salt. If you see over and over and over again the same issues with a provider, then you might want to pay attention. But
Mhm.
look at the good, look at the bad, average it out. If you're seeing things like, this person listened to my story, they really took the time to listen to me. Got my hormones back on track. They've got some training in functional medicine. They've got some training they've been seeing, hormone dependent patients for, this amount of time. They've been in this space. Then yeah, give them a try. See if you click with that person.
Mhm. And we are primarily talking about what insurance might cover
Yeah,
for somebody, right? So we're
that's
talking
right.
about providers that
Mhm.
take insurance. There
Mhm.
are obviously out of pocket
Right.
resources as well.
Yep.
Do you have any like tips or suggestions or
Yeah.
recommendations on that
Yeah.
front?
I would say so here we've it's akin to food quality. All right. So we've become, the pendulum has swung in a favorable direction in terms of food quality, I would say, in the last 10 years. So 10 years ago, everybody's looking for the cheapest food, right? Moms are shopping coupons in the middle of the grocery store, not shopping on the outer aisles. And that's the only thing that matters is what you can get for the cheapest amount of money, right? Now, I understand that money is tight and believe me, I save wherever I can. I know Ashley does too, and it's just being a good steward of your resources, right? However, there is something to be said about quality, and I will sacrifice things like vacations and cars and nails and hair and makeup and lashes and all of these other things. I will sacrifice that for food quality all day long. And I think that people have kind of come to this understanding that, oh, what I put in my body, I might need to spend a little more money on this because it needs to be quality. Now, I'm
Mm-hmm.
going to apply the same principles to your medical care. Now, I work in an insurance based practice, and I am fortunate to do so because my patients are able to use their insurance. We have to practice a little differently. We went over this on the primary care episodes, but we're in kind of a sweet space right now. I don't know if that's always going to be the case. A lot of functional providers have to go to a cash based practice. But here's what I will tell you, it is worth it. I
Mm-hmm.
realize that you have insurance. I know that there are some people, they will settle for the crummiest care because in their area, they don't have access to functional medicine places that will take insurance. And so you got to ask yourself some really hard questions, like how often am I eating out? How
Mm-hmm.
often am I getting my nails done? How
Mm-hmm.
often am I buying new clothes? How
Mm.
often am I, where am I spending my money? And
Yep.
if you've got significant health issues and you're banging your head against a wall with primary care providers or medical providers in general who aren't getting to the root of the problem, then you might have to go out of pocket for some of this stuff. And
Yeah.
it's just like food quality.
Now, we won't belabor this topic too much longer, but I do want to have your opinion on like finding a reputable non-insurance based provider.
Mm,
So like,
mhm.
functional medicine has become all the hype.
Oh, I know.
And so
I know.
just like HRT clinics, there's all
Yep.
these functional medicine
Yep. There
clinics.
there are people that take weekend courses, like literally spend 10 hours, looking at some PowerPoint slides, and then all of a sudden you're a newly minted functional medicine provider. Okay. So yeah, you gotta interview these people, see if they know what they're talking about. How long have you been in practice? How long have you been doing this? Are you know Find them on the socials. Are they practicing what they preach? That's
Mm-hmm.
the first place to start. Does this person do what they're telling other people to do? I think that's huge.
Yep.
Um, So yeah, it's just like anything else. It's you got to do some digging. You've got to take ownership of this.
Yeah, and I was actually talking to a group of ladies last night because 'cause they're kind of in this realm of kinda switching over to a more functionally minded,
Mm.
uh, care for themselves,
Mhm.
and I was just telling them, "You have to be your own advocate, you have to
Yep.
ask questions, and if your primary care is putting up a wall every time you ask a question,
Mhm.
that is a red flag, in my
Right.
opinion, and
Yeah,
you probably need to go find somebody else that is at
exactly.
least willing to have a conversation with you,
Right.
answer and entertain these questions that you have, whether or
Mhm.
not they think they are good questions or not.
Yeah,
I'm a
exactly.
I'm a firm believer
Mm.
there's no stupid questions.
Nope.
And you should not treat me like that it was a stupid
Yeah,
question. So,
absolutely. And that's precisely why some of the work that I do is consulting, right? Like I
mhm.
have licenses in Colorado and in Idaho, and so I will consult if someone has a primary care provider. I will consult on cases where it's a cash transaction, and if you want somebody functionally minded, you can often find a consultant who will look in on your stuff. They won't be responsible for your primary care, but if you've got some complex issues, then they can look in and say, okay, I think we need to do this. And they should have the ability to order the labs, to order the meds, to do all of the things that are needed to take care of you, as well as the ability to read the specialty labs that they order, etc. So
Mm.
yeah, it's a research project, but I can't really think of any more worthwhile way of spending your time and your resources is to reclaim your health.
Oh my gosh. Yes. Okay, so somebody's decided, all right, I'm gonna do HRT.
Mhm.
How long are we looking? Like, am I looking at a few months? Am I looking at several
Mhm.
years? Am I looking at the rest of my life?
Yeah, that's a really good question. And HRT isn't something that you just like go on and you stay on the same dose of absolutely everything forever. It's not a one and done kind of thing. These are fluctuating. Hormones are constantly fluctuating, and so we've got to make sure that you are within range. We've got to check in about symptoms. It's often a moving target. Now, it gets a little easier in the postmenopausal space because the body really isn't kicking out hormones anymore. And so it's like, okay, I think that we are stabilized at that very low level. And so you can replenish hormones at a fairly consistent rate and know that they're not going to be bouncing along the bottom, right? Um, so, how long? That is a question that is best answered between a woman and her provider. And here's why. We don't have definitive research that says women should be on hormone replacement therapy no longer than X number of years postmenopause. Okay. That doesn't exist. What we do see is that anecdotally, there are a lot of women who remain on this stuff for their lives and they get benefit from various hormone replacement modalities for their lives. So this could be something where you decide, okay, I'm getting enough benefit out of this. Your provider could say, okay, we're going to order these labs for you annually and we're going to see. And hey, your cardiovascular system is in great shape. You are not experiencing consistent UTIs. You are not experiencing painful intercourse and vaginal atrophy, and your skin still looks great, and all these things. And you could say, hey, I think I'm just going to stay the course. Or you can say, you know what? I think I've gotten through that into the menopausal transition, and now I'm postmenopausal several years. I think I have derived the benefit that I am going to get out of this. I'd like to try to wean off. And then there's everything in between too. I've got women who are only on, for instance, if they are having frequent recurrent UTIs, that's really dangerous as we age, because the symptoms are not the same as they are in a younger woman. And so we don't get the frequency, urgency, burning that you get when you're younger. And so those UTIs can go unchecked, and that is a terrible situation. They can become septic, and that's life threatening.
Yep.
So what we can do is, if a woman doesn't want to take systemic hormone therapy, we can administer vaginal estrogen, topical estrogen, that is just localized to that area. And it does incredible things without acting systemically. So, like I said, there's all, this is a very individualized kind of thing. This is not formulaic. It is woman by woman. You've got to look at the patient and not treat the paper.
Yep. Yes. That's great. So another question that I
Mhm.
know a lot of women might have, they're like, all right, it's too late for me. I mean, I'm
Mhm.
already in the depths of it.
Yeah.
I can't do hormone replacement therapy, or can I?
Yeah, so how late is too late? And I get asked this question a fair bit. And this is sometimes, guys, this is going to be provider specific. So there are some providers that don't feel comfortable prescribing hormone therapy if you have a 10-year window between, let's see, you haven't had a period for a year, so take that date and then fast forward 10 years. If in that 10-year period you have not had any hormone replacement therapy, then they would say, no, I am not prescribing hormones. They're not going to do you any good. Now, again, we don't have data. We have anecdotal experiences. I think we're starting to get some data finally, but this
Mm-hmm.
is a very unresearched part of health, unfortunately. So you can find providers who are comfortable prescribing in after that 10-year window.
Okay.
Um, yeah.
And I mean, this is a probably unfair question to ask you, but like, do you have initial feelings on that? Like, do
Yeah.
you?
Yeah, I do. I think, at least for my practice, I am very happy to let women try
Yeah.
and to just say, okay, you know what, we're going to start very low, go slow. I take very good histories.
Mhm.
And so I want to know, what is your cardiovascular history? What is your family history regarding stroke and
Mhm.
cancers, reproductive cancers in particular? And I look at all those things, and then we balance. Like, are you in the throes of osteopenia or osteoporosis? Can we get some protective benefit from this estrogen therapy along with progesterone?
Mhm.
Because I do have certain rules that I maintain. For instance, I never prescribe estrogen without a progesterone component. Period.
Mhm.
Unless it's just like a topical estrogen that's not going to act systemically. So yeah, I am one of those providers that is open to the conversation for sure.
That's awesome. So you've entered into menopause,
Uh-huh.
and you're
So you've
like,
had that year,
it's
right?
all, yeah, you've had that year. So
Mhm.
whatever date that is, 12 months later, you still haven't had a
Mhm.
period, but then all of a sudden you experience some bleeding. Is this normal?
Um this is a big question. All right. So let me just tell you what happens. From a provider's perspective, when you come in, it's called abnormal uterine bleeding. When you come in with complaints of postmenopausal bleeding, our mind goes to several places. Okay. There are
Death.
things. Ashley!
Just
Oh my
kidding.
gosh. Okay. I never lead with that. Uh,
You are
just,
dying.
just so you know. Yes, you have 2 weeks. No, that's awful. That's awful. No, but seriously, it could be due to all manner of things, but there are things in medicine that really give us pause, no pun intended, where we have to track something down, right? We have no choice, because there is a small chance that it could be something dire. It
Mhm.
could be uterine cancer. Okay. So let's start there. There is a 10% chance, 10% of women with postmenopausal bleeding, this is an early sign of uterine cancer. All right. So that's not an insignificant number, 1 out of 10. So
Mhm.
you better believe that we are springing into action with diagnostics and ultrasounds and imaging and referrals to gyne, and like all of these things will spring into action so that we can get that, okay, this is not what you have. And it's called ruling out. So we have
Mhm.
to rule that out. That is, the consequences of not ruling that out are so dire that that is the top of our list. Okay. Now, after that comes the 90%. So why is this bleeding happening? It could be from, something like untreated STIs, right? So we'll do testing for sexually transmitted infections. It could be from uterine hyperplasia. What this means is the uterus has gotten really thick. So I talk about these estrogen dominant states, right? Um, Potentially you could it would be a little, not on the rare side, but certainly down on the list. But you could have a condition where you are no longer cycling, but you have this thickened lining of the uterus. And so that could actually cause some bleeding. So it finally just kind of gives way and you have this bleeding,
Mm.
but you're already postmenopausal. Could be a uterine fibroid or a polyp. That's a fairly common situation. Also, it could be from this vaginal atrophy we've been talking about, because ultimately, the vagina is a tube lined with smooth muscle. And so it could come from the atrophy of that muscle. The skin gets really thin and there can be damage that's done, either via sexual intercourse or, any number of other things like an infection. Also from cervical inflammation. So that opening to the uterus is called the cervix, and it's sort of a donut shaped structure. And if that is inflamed, then that can lead to some bleeding. And then also there could be bleeding from other structures that are surrounding the area. You can have rectal bleeding that women think is coming from the vaginal area. And so you've got to, again, take this to the provider, because they need to take a look and say, okay, this truly is vaginal bleeding. Is it coming from the cervix? I would do a gynecological exam and one, make sure it's not coming from the rectum. That's very easy to rule out. And two, is this coming from the cervix? Is it coming from the vaginal wall? Where is this bleeding coming from?
Mm.
And so, yeah, it's got to be figured out. So if you're experiencing postmenopausal bleeding, then you absolutely should take that to your provider. Now, here is a caveat. One, always, 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 no matter what, even if you've got the situation that I'm about to present, you still need to take this to your provider because they will need to figure it out. But let me tell you something. So if I have a woman that is, let's say she is 2 years into her post menopause, and she comes to me and says, "Oh, I feel terrible. I think I want some hormone replacement therapy. Could we talk about this?" And I say, "Sure, let's see where your hormones are at." So I order some lab work. We talk through her history, and we decide together that some estrogen, some progesterone would be a good fit here. So I prescribe the medication. She gets on the medication. If the estrogen has too much influence in her particular body, you can induce a period. Okay. So estrogen equals bleeding, just so you know. If you give enough estrogen, you will induce a period. So that's why low and slow is the name of the game. You start low, you go up until the symptoms are controlled, You may induce some spotting, some bleeding, but all of that has to be then diagnostically evaluated, right? Because you can't tell. Even if I just started giving this to you 3 weeks ago and now you're having spotting, oh, it's obviously due to the estrogen I gave you. No, you don't have the luxury of that kind of thinking. You've got to rule it out. Then you can say, okay, it's not a reproductive cancer. It's not a uterine cancer. So we need to adjust what we're doing. So that kind of leads into the question of, should I be having a period in these postmenopausal states? So there are some providers who are of the opinion that you should, if you're providing HRT to a woman, that it is youthful and youth preserving to make sure that she is cycling every month, just like she was. Now, I am
Until
not
what
of this
age?
opinion. I am not of this opinion. That girl, there's some crazy stuff out there. So I am not of this opinion, and I'll tell you why. Because we are supposed to age. I know we all fight it, and that is fine, but we are supposed to age. And any time that you get growth and replication of cells beyond when they are supposed to, you are running into risks for cancer and
Mm-hmm.
malignancies as far as I'm concerned. And
Mm-hmm.
so what I do not want to do is force the continual growth and replication of that uterine lining by inducing a period with exogenous hormones. All right.
Yeah. So like, so somebody that's been on birth control their whole life,
Mm-hmm.
this is probably a whole nother episode.
Yep, I can already tell.
Uh,
Yeah.
but okay, when should they stop taking it if they are open
Oh
to
boy.
it?
Oh boy. You know what? Let's table that for another show.
Okay.
Because yeah, we should do a show on oral contraceptives. Yeah. There are a lot of women that have been harmed by, decades of oral contraceptives, and that is a whole nother can of worms.
Okay.
Yeah.
Because that's also inducing a potentially false period in later age if they're still on it.
It potentially could. It potentially could. With most of the formulations that we have now, I would say most women are on what's called a mini pill or a progesterone only pill. They're not taking the combo estrogen slash progesterone pills any longer. Because if it's truly used for contraception, then we can inhibit contraception with the progesterone only.
Mm-hmm.
And that does less hormonal damage than giving a combination.
Okay. But it
Okay.
does do other things to the body.
It does. Yeah, it sure does.
Okay.
Mhm.
So moving on, what are some of the potential side effects with peri or postmenopausal hormone changes?
Well, okay, so here's where it gets really frustrating, and here's where we see, and I'm not one to hop on the patriarchy train. I'm really not. I appreciate what medicine has done. There's a lot of things that we have not done well over the decades, but by and large, I think that the underpinnings of medicine have been to try and induce health in people.
Mm-hmm.
So I'm going to assume positive intent from medicine writ large, all right? However, when it comes to menopausal transition in women, that is where we are woefully lacking in information. So right now, if you go into most conventional practices, if you are not experiencing hot flashes, there will be no hormones offered to you. And sometimes even if you are experiencing hot flashes, then you won't get any hormones. But um but we know now that there are so many things associated with these hormonal changes that it's not just hot flashes. I mean, that's such reductionist thinking to reduce all of menopause and everything that a woman experiences during this tumultuous time, to reduce that to, well, are you having hot flashes? Okay, go sit in the fridge. Like that, basically that's where we're at. That's where
Mm.
we're at. But no, we know that there are things, and I'm just going to go through this list. I made this list off the top of my head, and I know that there are 50 more things that I have missed. But listen to this. So frozen shoulder,
Mm-hmm.
that is primarily associated with women, and it is associated with menopausal changes. Musculoskeletal aches and pains. These can be profound. I've talked about my own experience with this. Incredible, debilitating joint aches, painful intercourse, loss of libido, recurrent yeast infections, painful urination, recurrent UTIs, bladder and kidney infections. How about chronic cough? All right. So
Mm.
we've talked about the fact that, that loss of estrogen dries out membranes, right? So we have painful intercourse, we have vaginal atrophy, we have dry skin because it dries out your skin. It dries out your mucous membranes. And so because of that, you can get things like chronic cough because you've got these dry throat mucous membranes, and that's highly irritating. And so they'll get this chronic cough. Now that can also be a sign of various cancers, and it can be a sign of some medication that you're taking. So you need to get chronic coughs checked out, period.
So
But
that would be like just getting your hormones checked,
yes,
potentially.
yes, get your hormones checked. Yes, yes. You also need to be interviewed for, could this be a possible malignancy with a chronic cough? Because sometimes that's the only symptom that you get. So if you got a chronic cough, you need to get it checked out. But it could be a sign of menopause. Also, how about vertigo? I have had more
Mm.
women having issues with vertigo and tinnitus. So they've got new onset ringing in the ears. So that is also associated with hormonal changes. Also, cardiovascular, heart palpitations. So you can have changes in your heart. You can notice palpitations or pounding. Or even rhythm changes. So it's like, I feel like my heart kind of skips a beat. Yeah,
Not a
it
good
can,
way.
and not in a good way, and not when you see your baby. Um,
Um,
yeah, so we talked about, the dry skin, dry mouth, poor oral health despite good oral hygiene. Because if your mouth is completely dry, we talked about this on or did we do an oral hygiene episode? I'm pretty
yeah,
sure we
yeah.
did.
Mhm.
So we talked about all the dangers of dry mouth. And
Uh-huh.
so also headaches. Headaches are a huge one. Headaches are a lot of times hormonally motivated in women, especially the chronic headaches. Changes in skin quality. So women it's almost like overnight you wake up and it's like, whose skin is this? This is terrible. This looks like my mother's skin. It's crepey, it's dry, it's got like a weird quality to it. Like it's not holding moisture anymore. Um, and then you can have also chronic sinus infections, okay? Back to the dried out mucous membranes. So
Mm.
you've got dried out mucosa in the nasal passages, and that is a perfect entree for bacteria. So chronic sinus infections. Also, there can be this chronic runny nose that happens. Menopausal changes. How about
So
neurologically?
crazy.
Oh, it is nuts, nuts, and it affects your cognition big time. Brain fog, word searching, cognitive decline, dementia, Alzheimer's disease associated with women who are not on hormone replacement therapy, and that is in the literature, so you can go find that. Osteopenia, osteoporosis, bone loss, bone density. Remember, the dairy industry wants you to drink gallons of milk a day. However, we don't need to do that. We need estrogen and we need weight-bearing therapy, otherwise known as exercise. It will also increase visceral fat deposition and cause body composition changes. So it will take fat from visually appealing places and put it on not appealing places. And you just be like, wait a second, these clothes used to look way different. Um,
Yeah.
Also, it will cause horrific issues with insomnia. And then I get down to, okay, so that's my off the top of my head list. Then I get to hot flashes. Okay, big whoop. This is literally the only thing that hormone replacement therapy is approved by the FDA to treat. Can you believe that? We use it off label for all of the above, but that is what it's approved to treat. And so
Wow.
a lot of practitioners will hide behind that and say, well, if you're not having hot flashes, then, there's nothing to treat here. That's the only reason that I would write for a hormone is because you're having hot flashes. Okay. Vasomotor symptoms. I mean, that's, yes, um, they can be really ruinous to portions of your life. They can be very interrupting of your life. And they're hard to deal with. They really are. But you can see from this list, there's a million other things that there is to deal with also. Oh, did I even mention like muscle atrophy? Did I even mention that?
Yeah, I
I
think
don't, yeah,
so.
okay. Yeah, so anyway, there's so many issues that
Yeah.
can be addressed with hormone replacement therapy.
It's crazy.
Mhm.
And Andrew and I listened to a really cool podcast. It's a couple
Is that the one
podcasts
you
this
sent
week.
me?
Yeah.
Yeah, that was
And there's
great.
definitely research coming out, and I hope it's really we're gonna start seeing a lot more of this research, specifically on women, and
Mhm.
hormones and HRT, and all the things. Um,
Yeah. Mm.
so do women only need, I think you've kind of already touched on this, but do they only need estrogen to be replaced with HRT? I think you mentioned that you specifically, if you're doing estrogen, you always do a progesterone as well. Is that like always?
And that is excuse me, that is always. Yeah, with the exception of like um very localized topical administration, but yeah, I can't think of an exception actually in practice right now where I have prescribed estrogen only. There's
Okay.
always progesterone in the mix. And so yeah, even if hot flashes are your only symptom,
Mm-hmm.
you want the protective. So estrogen treats hot flashes, period. That's what we know. It treats many other things too, but it treats hot flashes. So if you're having hot flashes, that is excuse me, that is the body's first clue that estrogen is dropping. Because as I told you, is that better?
Mm-hmm.
I had my mic up by my head because I was drinking coffee, so you didn't have to hear me slurp. So as I mentioned before, when you're in the peri state, I'm sorry, I have a frog in my throat. Okay. When you're in that perimenopausal state, your hormones kind of bounce along the ground, and very often you can get into an estrogen dominant position. So I will very often start off by prescribing progesterone only. Okay. Now then, as you progress throughout this transition, the estrogen will eventually go down, and so then we will need to replace it. Okay, but progesterone a lot of times will come first. So if you're having hot flashes, then that is a clue to me as the provider that like, okay, so this woman is entering an estrogen deficient state. Okay. So, but no, you don't only need estrogen. In fact, a lot of times we can get by with just progesterone for a long period of time. Now there's also testosterone in the
I was
mix.
just about to ask about that.
Yes. So, and this generally will occur later. Again, it is highly dependent on the woman, but we have lots and lots of women struggling with PCOS. And this is an androgen heavy condition. And so those women who have PCOS, they go into perimenopause with an already elevated testosterone. And so actually that becomes a good thing. later on in life, if their bodies have a propensity to be androgen heavy, then that means they go into perimenopause with physiological levels of testosterone, and that can carry them for quite some time. And so I don't have to replace testosterone in these women. But again, it's something to keep track of.
Okay.
So yeah, I would say that all three are necessary.
Okay, so I think we've touched on it slightly, but just to give a one-stop shop, how often should hormones be checked?
Mm.
So say I'm 39, I should be having them checked every year. That's
Mhm.
baseline, right?
Mhm.
Then once somebody starts entering into perimenopause and they start
Mhm.
seeing some of these signs and symptoms,
Yes.
obviously get your hormones checked and then potentially every 6 months from there,
Yeah,
or
so you actually mentioned the buzzwords here. Signs and symptoms. So, until you're having signs and symptoms, but like we said, the signs and symptoms are crazy.
uh-huh.
Like they are head to toe, right?
Yeah.
So if you've got weird stuff going on that cannot be accounted for. So again, all of the above, all those things that I listed off, they have a myriad of potential causes. This is why it's so important. Like I cannot tell you how many hours and hours and hours that I spent learning diagnostics in school. All right. It's because it's really important. One, you don't want to miss anything big. That is every provider's nightmare. Is that's what
Mhm.
keeps you up at night wondering, oh, did I miss something here? Did I miss something big? Okay. So we go to school to learn diagnostics. That is a huge part of our job. And so when you come in with nagging symptoms, it's our job to get to the bottom of that. And uh, if you've got something that's not going away that cannot be accounted for by another thing, I can't resolve it in another way, then we need to check your hormones, right?
Mhm.
Especially if you're within age. And so, if you're in your mid to late 30s and beyond, that's when we start checking. So, like you said, you're 39. I would absolutely check yours annually. Now, to my knowledge, I'm pretty sure I'm the first one who would know if you were having something going on. And so,
You have
so
no
I
idea.
yes, I would receive a multitude of text messages. And so I would tell you, yes, we need to check your hormones. But then once we've checked them, if things look okay, then we'll check them in another year.
Mhm.
And then when we get to the place where you're just like, okay, I am having these lingering symptoms, then let's go to an every 6 month kind of thing. If things start to look a little wonky, at the first sign of that, either because of lab work or because of signs and symptoms, then we need to start checking every 6 months.
Okay. Perfect. So we kind of touched on the types of hormones, obviously,
Uh-huh,
but
yeah.
what are some of the choices for
Uh,
administering
mhm.
HRT?
Yeah, this is a really good question, and I have this conversation with patients all the time. So, there are choices that you have in hormone replacement therapy. We talked about, let's just start with estrogen, okay? So, estrogen, we have basically there is a bioidentical hormone, all right? And these come from compounding pharmacies primarily. All right. There are some commercially available bioidentical compounds of hormones, but they are made by commercial pharmaceutical companies. They are available only in a few strengths. And a lot of times what I see with these is that they have what we call pharmaceutical excipients. These are other ingredients that are either fillers in oral formulations, or they can be adhesive when it comes to patches. There's all kinds of things that these pharmaceutical companies will put into their products. And generally, it's about stability, right? Shelf life of medication. And people can be very sensitive to these things. All right. So it can cause problems. I think I've talked about progesterone. There is a bioidentical commercially available progesterone. And if I have a woman who has real financial constraints, then I will have the conversation that, okay, based on your history, you may be a good candidate for prometrium. This is that natural progesterone that's available commercially, and we can try it. But here's what I see a lot. A lot of women have terrible headaches on this stuff. Now, the manufacturers claim it's bioidentical, it's perfectly natural, it's this, it's that. But when I switch them out and I put them on bioidentical hormones that come from the compounding pharmacy, compounded specifically for them, the headaches go away. So, also, Prometrium only comes in 100 milligram capsules, and so it actually might come in 100 and 200. But I frequently will write for 25 milligrams, 50 milligrams. I can write prescriptions for slow release formulations from the compounding pharmacy, which I love because I have women take it at night. They get great sleep, like sleep that they haven't had in years from bioidentical progesterone in a slow release formulation. So there's so much flexibility that we have with bioidenticals, but again, it is more expensive than the commercially available, and insurance often will not cover any of it.
Yeah.
So then estrogen is next. There are primarily what we're talking about with estrogen. I think I've mentioned that I really only use transdermal estrogen, like that can be rubbed on thin skin areas of the body, like the forearms. This is what I write for. I write for bioidentical coming from a compounding pharmacy. There is a commercial formulation in the form of patches where you can get, these transdermal patches are usually dosed twice weekly. I generally will have women apply the cream to their forearm nightly. So again, I have so much flexibility. I can order combinations of estradiol and estriol to get the exact effect that I want in a compounded formulation. I don't have that option with a patch, right? It's just an estradiol patch. You slap it on, you get the exact amount that the manufacturer has prescribed, and I can't change it. So then testosterone is the last one. Now, there are no commercially available testosterone preparations for women. We can use men's formulations in women, but I would invite you to think about the logistics of this because it is ridiculous. There are these packs of gel. So first of all, most men who are on testosterone replacement therapy, they will either have pellets, which I don't care for these. I'll tell you why in a minute. I think they're terrible, but pellets, or it comes in like a transdermal gel or a cream. Okay. Now, I'm sorry. So no, men will either do pellets or they'll do injections. All right. So these are such incredibly high concentrations of testosterone. We can't give anywhere close to that to a woman.
Right.
It would cause terrible, terrible effects. All right, so think about this. There is a gel that is available for men, and you might think, oh, okay, so we could actually use the gel because you could just use like teeny tiny little amounts of it. All right, how are you going to do that? So you've got this little tiny packet that a man is supposed to use one a day. All right. I need about 1/10 of that for a dose for a woman. And she might need it like every other day or every 3 days. So are you supposed to open that little tiny packet like a sample of shampoo, figure out exactly what 1/10 of that is, and then somehow seal it back up every day so that you can use this over the course of 10, 20, 30 days? It's a logistical nightmare, and you can't get any kind of standardized dosing out of this. So I have seen women get pellets injected into them with testosterone, like slow release testosterone. I think this is awful. You cannot dig those pellets back out. It doesn't matter what's happening in the body. You can't dig them back out. And it's like it's a procedure. Every time you have to get these placed, which is every few months, you got to have somebody cut your skin open and place these pellets underneath your skin. It's awful. I think it's barbaric. I am not a fan. I think it's a terrible way to do hormone replacement therapy for a lot of reasons. But Let's see. So what I do with testosterone is again, compounding pharmacies to the rescue. These folks are amazing. They will make whatever formulation I order. I can order it in whatever strength I want. If a woman is also on estrogen, I can order the estrogen and testosterone in the same cream, and then I can adjust the strengths accordingly. And it comes in something that looks almost like a tiny little deodorant container. All right. So you turn the base of it and you get one click, and that is 1/4 gram. And so I can write for 1 milligram of estrogen per gram of cream, or 50 milligrams of testosterone per gram of cream. And then I can say, okay, you need to use 1 click at night. And then, if you still have symptoms, we're going to go up to 2 clicks at night and see how you do. So it's highly, highly flexible. So I get a ton of flexibility in dosing when it comes to bioidentical compounded formulations.
And again, whether or not insurance will cover that,
Yep.
it's not known.
Yeah, that's right.
It just
It's kind of the realm of the GLP-1s now, right?
Yeah.
Because most insurances won't cover GLP-1s. And
Mhm.
actually, I'm not even sure that they should. Like, for most people who are using this for various things, I mean, yes, they're great drugs, but it costs the insurance company like $1,000 a month to pay for these commercial preparations. So if you're wondering why your insurance premiums are going up, it's
Mhm.
because of all of these really expensive drugs that everybody thinks ought to be covered. And so you end up paying in the form of increased premiums. So before we know it, we're all going to be priced out of insurance. Like, there's so much wrong with this system. It's ridiculous. But anyway, so
That's a whole nother day for another
yeah, oh,
yeah.
I know it. I know it. So anyway, compounding pharmacies to the rescue. They can solve a multitude of problems, but again, often these things are out of pocket expenses.
Yeah. Well, I think that wraps up our
Mhm.
series, but as always, if you
Ah,
have more questions, if you would like us to cover something that was not discussed in these last 6 episodes,
was it
please
6
reach
or was it
out
5?
to
I think it
I
was
think it's
5.
6.
Holy moly. All right.
I think it was, I don't know, 5 or 6. I can't remember.
Okay, well,
But if 1, 2, 3, 4, 5. Yeah, I think it was 6. Um, no, 5. It doesn't matter.
it doesn't matter.
Um, if you have more questions, definitely reach out to us, askAApodcast@gmail.com, or reach us out on our socials. You can also leave a little note on whatever platform that you're listening
Mhm.
on, and we will get that. I think that's just Spotify. I don't know if you can do it on Apple, but
Hmm.
Spotify allows you to leave a comment, so we would love
Oh,
to hear from
cute.
you. And as always, if you find any of these episodes helpful or beneficial, we would be most honored if you would share it with your friends and family, whether that via text message or even on your socials. And if you do on your socials, please give us a shout out because we would love to give you a shout out. And I think that'll do it for today, and we will see you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.